Thank you very much for inviting me to speak about MR neurography of the lumbosacral plexus, how I do it. I have nothing to disclose. About myself, I'm a 46-year-old general radiologist with a focus on MSK and MR imaging. I work for a team which have 50 board-certified radiologists and 16 residents. Our institute is located in Switzerland, or right in the middle of Europe. For us, MR imaging of peripheral nerves is a daily routine business. We have steadily increasing numbers, and especially the lumbosacral plexus, which is a complex anatomic structure, is quite a common clinical referral for us. I have worked in the last years about getting good referrals from our referring physicians. We had to educate them. I gave a lot of presentations and also spoke personally to them to really get a good selection of patients for MR imaging. I typically ask them to limit the field of view and to narrow down the potential differential diagnosis so that I know what I have to look for when I do the imaging, to not lose time and to properly address the sequences to the clinical need in the patients. I am quite happy when the clinicians use pre-MRI ultrasound to narrow down the potential differential diagnosis so that I don't have to do the exam from the pelvis to the great toe, but to really focus, for example, on a specific anatomic region. I try to use the best imaging hardware possible, 3 Tesla machines, best gradients, so that I can achieve a homogeneous B0 field. We have tried a lot of patient positionings to come out with the best solution. Fixing devices are used quite extensively, and I will talk a little bit about bowel motion and respiratory triggering in the next slides. Coils are always very important in imaging. I have presented here a selection of coils which I used in the past or we are currently using. Philips D-stream technology is for sure superior to non-D-stream on Philips platforms. Siemens matrix coils are very have a very high potential for good image quality. I do not know if this 16-channel coil is still available in all markets, but it's a very good coil for pelvic imaging. The same on the GE platform, they have very good coils available for their systems, especially new air technology is really superior to the previous coils in my opinion. And there are even independent manufacturers who produce very good coils that can be used for pelvic MRI. To the best of my knowledge, there is one vendor, which is Philips, who have brought a specific nerve sequence into the market based on a publication or development from a group in Japan. That particular sequence, which was called 3D Shinkai in the publication, uses a fat suppression technique, a vessel suppression technique to improve two-weighted sequences based on a 3D sequence to achieve the best possible image of nerves in the periphery, including the plexuses. This is a marketing image from the website of Philips, but I can assure you that even in real life, you can achieve similar image quality. This is an example for this sequence on a normal clinical system. You can see that there is a really good image quality and the plexus structures are well visible. However, in real life, especially in the lumbosacral plexus, you have a lot of clinical problems or daily problems. Images are typically hampered by breathing artifacts, wrapping, bowel motion, noise, and inhomogeneous fat suppression. How do I overcome those limitations? Well, for patients with high BMI, there are not so many options. Try your best, but do not be frustrated if you will not achieve the best image quality. That's natural. Bowel motion, you can use Buscopan against bowel motions. However, sometimes if you have a long scan time, you need to administer it twice. Breathing. I have tried respiratory triggering, but the effect was mainly that the examination time went up, so I do not use it anymore. Metal artifacts are a constant problem from various sources. There is a very nice article published in Radiology now in August. I recommend reading it. It's very helpful for the daily routine. Susceptibility artifacts from air are also an issue. You could fill up air spaces such as the rectum, but I think it's not very comfortable for the patient. So just live with it or wait until the air disappears. Inhomogeneous fat suppression is also a huge problem. As you can see, there is also a publication out there published in June this year, which deals with this kind of problems, especially using 2D Dixon sequences. I also can recommend reading this publication for further details. I have some protocol suggestions. In my experience, axial T2 weighted sequences, simple T2 weighted sequences without fat suppression are very helpful in the pelvic region. They produce reliable images with good SNR and good conspicuity of the nerve anatomy, as you can see on this example. I also may recommend to use some kind of axial T2 weighted fat suppressed sequence for the detection of abnormal high nerve signal and easy recognition of nerve thickening. Please do not produce images like on the left-hand side here, but try to achieve images like on the right-hand side, nicely fat suppressed with good visibility of the nerves as indicated by the arrow. 3D sequences may be used, but they are usually quite tricky and in my experience more tricky than 2D sequences. MPR may be possible and there are some new advanced sequences out there as shown by a recent publication published in May in Skeletal Radiology. I also recommend here reading these recent articles for further details. I do not use DVI in clinical routine, neither do I use DTI. I always perform a 3D or 4D angiogram when I use contrast, and I use indeed contrast quite often in the pelvic region. I try to stay with the patient when I do exams and do some kind of personalized medicine for them. And my experience, it's worse because the examinations anyway take quite a long time. It's important that you know the anatomy of those little nerves around or arising from the spine and the lumbosacral plexus. Use a e-anatomy-atlas if you are not familiar with the anatomy. It's very helpful to detect the tiny nerves. This is an example of the lumbosacral plexus, and this example should show you that the peripheral nerves have contribution from different nerve roots. And this contribution can be seen in the peripheral nerves because, for example, in the sciatic nerve, the L5 and S1 contribution can be seen all along the length of the nerve on the various heights at the thigh level. So if there is one nerve root affected, you will see it along the peripheral nerve, and that's very typical, especially for the sciatic nerve. Last but not least, you need to know your diseases. If you're not familiar with your diseases, you will not detect them. And I always try to provide a structured report to my clinicians. I use always the same structure, as you can see here in this German version of a report. And my clinicians are used to these kind of structured reports. Lastly, I try to provide nice 3D images for them, especially when I do my rounds. Thank you very much for your attention.